Start in 7 seconds. Wonderful. And welcome to the 988 Crisis Jam. My name is Megan Haupt. I'm the Chief of Staff with the National Association of State Mental Health Program Directors. We are in Season 5, Episode 227. And today's featured presentation will be Dr. Jennifer Lockman to talk about Thrive, which is a brief recovery-focused intervention. So thrilled to have Dr. Lockman on the jam today. And just some housekeeping items. So just remember to please stay off mute unless you are a presenter and it's your turn to present. You can select speaker view, which is in the upper right-hand corner, to be able to see just the speaker instead of a gallery view if you choose to do that. To join in, we would love for you to share your thoughts and your questions in the chat. If there's a poll, and I believe there will be 2 of those today, be sure to answer in the poll and not in the chat. So great, welcome. And just want to emphasize the new ASL feature. First of all, it's great that the 988 Crisis Jam provides ASL interpreters. We love that it's inclusive and welcoming of people who are deaf and hard of hearing. It's just a great model for that. To get to the ASL feature, you can go to More in the bottom right, those 3 dots, and you can choose the ASL feature. Some people also have a globe icon at the bottom, and that will also allow you to do that. And the ASL box, the person who shows the interpreter, you can move them anywhere you want on the screen. So very cool. Thank you. And we have had over 200 episodes. We're now 226 episodes. We're on the 227th since 2020. We've had 574 unique speakers, including today. That is amazing. And if you've got a hot topic, if you've got something you want the Crisis Jam to address, please let us know. You can put it in the chat box. Let Kristen Ellis from Recovery Innovations know, and we can consider that. So look at all those. That is phenomenal. We're going to show this a little differently in our next season because we are just getting packed with speakers and we love it. So, all right, next slide. And we also just want to kind of emphasize the website there, talk.crisisnow.com. That is where you can see the different ways that the 988 Crisis Jam learning community can be shown. You can see past episodes there, past materials. You can see at this website that it shows what's happening today. We also have the opportunity to see it live streamed on YouTube. And of course, we always most encourage people to register for the Crisis Jam. You have to have a Zoom account for that. You're vetted, but it is a great way to interact in the chat box. So there's that register for the Crisis Jam link. And we encourage you to go to the website to do that. Again, these are some past episodes, materials, different ways to see the materials. We did learn that the materials link we have so many materials that it got a little overloaded. They're fixing that. So, but do know that will be up and running very quickly. I think the last episode is, the most recent episode is up there. Great. And the neat thing about our episodes, there are different formats. I love how the Crisis Jam just keeps things fresh. So there's the a day in the life. I'm about to sneeze. Hang in there. It's coming. Okay, no, it went away. All right. Okay, that's hilarious. All right. So we have something called a day in the life where it's actually interviewing people that work in a particular part of crisis services, and we learn more about their inside experience. There's live and on location, and we've had a few of those where we actually go to the location, we actually film it, and learn about that location. We have the debate format, where somebody takes the affirmative and somebody takes what we call the alternative perspective. So it's not necessarily a negative perspective, it may just be different. And we also have something called a fireside chat, which is kind of going into more depth of an interview about a particular topic. So very, very exciting. If you go to YouTube and see some of these or past episodes, like and subscribe. All right. And season 5, some of the debates. Just the debate format is so cool. So here's some upcoming ones. So August 27th will be Paul Galdis and Dr. Joe Parks to discuss states should prioritize building capacity in the 3 core crisis services. So Paul Galdis will take that perspective that states should prioritize it. And Dr. Joe Parks will take a more alternative perspective on that. Again, that's August 27th. And September 17th, David Covington and Dr. Jessica Pollard will debate whether coordinating follow-up care and crisis services requires high-tech software solutions. So David Covington will take the affirmative on that, and Dr. Jessica Pollard will have an alternative perspective. So it's very cool to have the alternative perspective because I think it can really open our minds that things don't have to be one way. And on the other hand, being able to see things in a model is also an important part of things. Thank you. And season 6 is going to be Crisis Jam Unplugged, and that is September 17th. That's when it starts. So I don't know what unplugged means, but we encourage you to join September 17th to find out what it means, because it's a surprise. All right. And let's go to the latest crisis news. So what's really cool, they're going to have a 988 day workshops. So they basically are ways and activities to celebrate that 988 day. Their ideas, it is sponsored by SAMHSA, and the theme is compassionate help anytime, anywhere. So they're awareness raising ideas about 988. So fantastic. Also, there is an NPR article on the 3-year anniversary of 988 and how it's been used. The millions that have accessed by calling or by chat and text, just incredible. Like a kind of an objective article on it. And I think that's important, but also celebratory in terms of a 3-year anniversary of 988. So thank you. Okay, and the Texas Tribune highlighted how mental health programs could bear the brunt of a $600 million federal cut to Texas schools. So the difficulty with this is Texas doesn't necessarily have a way to replace those funds through state funds. So they're kind of bracing for this. And Texas isn't the only one. There are other states that are having challenges with this as well. But this article may be helpful in terms of maybe how Texas is facing this. Thank you. Also, there's an article in Fortune, the mental health gaps employers can't afford to ignore. So the traditional way of addressing wellness through employers has been like brief EAP, maybe a few sessions, but there's higher stress, the recognition of higher stress. And so this article discusses that. Great, thank you. And you can see some of the comments in the chat that are substantiating what I'm saying. So please take a look at those about what some of these articles are saying. And the Crisis Jam Showdown. So this is like a pretest to the feature presentation. If you know the answer to this, fantastic. I think pretests help us prepare and alert our brains to what's coming. So this is Thrive C is a brief recovery focused intervention designed for crisis stabilization centers, CSCs. It builds connection and meaning in just one session. So which of the following is a component of the Thrive C model? Is it A, daily behavioral tracking logs, B, structured medication adherence checklist, C, autobiographical life narrative, or D, risk scoring with predictive algorithms? And so please put your guess or your knowledge in one of these choices in the poll. Okay. So very interesting, right? Let's take a look. Wow. So it looks like things are pretty split. The daily behavioral tracking log got 19%, structured medication adherence checklist 15%, autobiographical life narrative 38%, and risk scoring with predictive algorithms 28%, but most pick C. If it was up to me based on this, I would say C, but let's see what happens. Look at that. We have a smart audience. Thrive C includes narrative-based strategies like the autobiographical life narrative to help people reflect, reconnect, and create a meaningful living plan during moments of acute crisis. It's brief, trauma-informed, and grounded in recovery, not surveillance. Very cool. Autobiographical life narrative. So thank you. Thank you for who came up with that question. So now we can see more in our feature presentation what all of this means. Really delighted to have Dr. Jennifer Lockman, who is going to talk about Thrive with a brief recovery-focused intervention. So let's go to Dr. Lockman.
Hello, it's good to be with you all today. I'm so thankful for the opportunity to present.
You got on mute there. Let's take you off mute.
How's that?
Great. Thank you, Dr. Lockman. Great to see you.
Awesome. Thank you. Great to be here. And I'm really thankful to be here among this learning community today. I love that we have so many people coming to learn about Thrive and learn about other becoming practices in crisis stabilization and beyond. And so if you go to the next slide, please. Just wanted to start with our disclosures and collaborations. I do have research grant funding from NIMH, a multiple PIs award to Dr. Pisani and Lockman, and also my AFSP Early Career Investigator Award, and Dr. Pisani was the mentor on that. And so we're very thankful for the funding opportunities to be able to do this research. I am also the intellectual property holder of Thrive and Relate interventions, and thankful for the opportunity to be testing those in partnership with community. Last, but certainly not least, team science does not happen without team, and really visionary leadership teams and individuals who are in practice that are willing to do this with us. And so definitely wanted to acknowledge the leadership teams at Mental Health Cooperative and Connections Health Solutions, and also all of the people who have helped us there in terms of their staff, in terms of learning about Thrive and doing this work together. And it's been a wonderful journey and amazing opportunity. So thank you. So just to tell you a little bit about me, I work for the University of Alabama at Birmingham, and I'm an assistant professor here. I currently work in the Depression and Suicide Center and have several different identities. UAB is a wonderful place to work. It is the eighth largest in the nation in terms of our UAB hospital. The footprint of UAB, which you start to see here in the picture, it has over 1.4 million square feet, and we see 1.6 million patients a year. And so we're able in this wonderful area in Birmingham to really work together in a team science and practice-based partnership model to really deliver the very best care today that science would indicate that we should be giving to people, and also innovate the care of the future. So to advance a couple slides, please. Okay, next. And this is a little bit about me. So I am a counseling psychologist by training and also a suicidologist. I've worked in suicidology all of my professional life. I currently work, as I shared, at the Depression and Suicide Center at UAB. I'm mostly research, but also lead a clinical practice there in partnership with social workers, psychiatry residents, and also postdoctoral students and graduate students. We have a wonderful specialty clinic for suicide recovery to where we're really working hard to deliver all of the best practices for suicide prevention that we know today, while also using research to innovate care for the future. And so we're so grateful to be able to do this work there. I wanted to also mention just in terms of my professional roles, I also have previously worked at Centerstone as their CEO for the Research Institute. And I do think that my experiences there have really enriched my understanding of community-based environments and practice environments. And I'm thankful to be merging these together in the journey that I'm on. So our lab at UAB, we are really focused on partnering with healthcare leaders, communities, and people with lived experiences of suicide to understand recovery. We are really open at this place of really wanting to use everything that we know works in suicide prevention, but also starting to extend that to understand, how does recovery work? What are the psychological mechanisms, the clinical processes of recovery? And we think about recovery, we want to understand not only the clinical processes, clinical recovery. How do we reduce symptoms? How do we reduce suicidal behaviors and the desire to die? But also personal recovery. How do I grow? How do I develop as a person from these experiences? And how do I put those things together toward holistic wellness? So we really want to understand in our lab how recovery happens, so that we can help infuse that into developing and testing new interventions to promote holistic recovery, and also adapting and setting implementation strategies for how to do this recovery-focused work in healthcare systems and in communities. Next slide, please. So I'm here today to talk a little bit about Thrive, which is, and we're focusing today on the brief intervention that I've developed called Toward Hope, Recovery, Interpersonal Relationships, Values, and Engagement. Next slide, please. And just to give you a little bit of background about Thrive and how it came into being, it's really known among individuals here that ED crowding is a significant concern, and crisis stabilization centers have developed in part to fill that gap, to give people, coming from all different kinds of places, ED 988, a place to go to where they can grow in their experiences and also find health and wellness again. But crisis stabilization centers today, just from a pure research perspective, we really have mixed support right now in terms of what's happening, how are people getting better? And so part of our goal for Thrive is to understand how do we fill that gap, including having brief and effective recovery-focused interventions that staff can be trained easily and quickly and cost-effectively to do well, that really create both clinical and holistic wellness recovery outcomes. And we're looking at both of those. And today, just from a counseling perspective, we don't have interventions that are evidence-based, that are brief, effective, recovery-focused, with also known potency to decrease suicide attempts and deaths. Our sense is that if crisis stabilization centers had these, they would kind of elevate our opportunity even more to live the mission of being recovery-focused spaces in the community. But today, our existing interventions for suicide prevention that work very well in outpatient settings with wonderful research support for outcomes, things like CAMS, DBT, brief BCBT for suicide prevention, great in those settings, but wonderful outcomes, and we don't yet have evidence that we can shorten those or shorten versions that have the same outcomes, including in treatment engagement as people continue their path in the community. And so we hope that Thrive fills this gap. And so some of the research I'm going to be talking about today talks about how we have approached that process of learning about Thrive. Next slide, please. So this is the CSU Mental Health Cooperative where some of this research started. And I wanted to share this story of, I was a very unique place when Thrive came into being. I was doing my postdoctoral fellowship at the Center for Excellence for Suicide Prevention at the VA in Canandaigua. I was working in part and had experiences with Centerstone, and they were exploring at the time opening a CSU, and then Mental Health Cooperative was down the street. And so Adam Graham was leading the CSU at that time, and we had lovely conversations just in terms of learning about, where is, crisis stabilization falling in the crisis continuum, what needs to be happening. I was kind of aware of some of the structural and other kind of community-based barriers to care access when we try to refer people to community mental health. And so it was between those conversations and others I was having nationally with all kinds of practice partners in the community. We started out, and I wanted to say we started out with the aim of saying, can we shorten an existing treatment, based on what we know works about it? But the more we talked about it, the more it became clear that something else might be needed. Next slide. So this was part of our thinking at the time, and it certainly evolved. And this is a simplistic graph for a complex problem. But part of what I was, talking with people about all across the country when Thrive came into being is that when we want crisis stabilization centers to be a place that draws people in. These are mostly walk-in centers. They can be police drop-off centers. We want these to be places where, family members, police officers, individuals themselves can come to a crisis stabilization setting and believe that this is going to be a turning point for them, that this is going to help them restore a sense of wanting to live, a sense of how do I live next. And as we talked about it more and more, typically what may happen in a current care setting is that we try to engage people and draw people in and focus quite a bit on safety and stability throughout the episode of care. And physical safety from suicide is extremely important. Certainly doing a suicide risk assessment, the Stanley Brown Safety Plan or other evidence-based safety plan, counseling on lethal means, escalating the level of care where needed. These things are really important. We want to keep people safe from harming themselves by suicide and death by suicide. And as we talked more with people with lived experiences and our practice partners, it just became really clear that this by itself didn't seem like enough. It didn't seem like enough that to really have confidence that by itself we were able to engage everyone on a path to growth and a path to recovery, and including people who were in a state of ambivalence that they weren't yet able to seriously think about safety. And we see this in other environments too, documented, including the emergency department. So the sense was, what is something that could really engage everyone to say, if you come here to a crisis stabilization center, you are going to be seen in a way that you have never been seen. You're going to be heard in a way that you have never been heard. And together, collaboratively, we're definitely concerned about your safety, but as much of that, we're concerned about how do we help you get your life needs met? How do we help you either get your life back if that's something that's contributing to wanting to die, or also build a life that you always wanted, that for different reasons and life losses you no longer believe is possible for you. And so our sense was that if we could engage people from the beginning, not just on safety, but in this holistic recovery narrative and experience, that it might help with some of the known problems that we have in terms of making care transitions and people having sufficient internal motivation to work through all the resource gaps and challenges in our care systems to get to that receiving outpatient provider. It might help with the kind of going on and doing hopefully a suicide specific or other psychotherapy treatment, because right now there's very high dropout rates in psychotherapy, especially in community mental health systems. Nationally, the average number of sessions is between 3 to 6, depending on how many, what study you're looking at, and that's not really enough to complete one of those treatments. And so the idea is, if we're looking at this, getting everybody to this recovery and post-traumatic growth space today, not everybody's getting there. And maybe this kind of safety and stability gateway of saying, like, this is the one way we know today to get people isn't working as holistically as it could. And it might be time to rethink, both use what's working 100% for everyone it can work for. Again, these are very established evidence-based interventions. I use them in my own practice every day, but also do more to say every person, no matter how you come in today, we have a pathway to engage you on a path to holistic wellness and rebuilding your life. So next step. So I'm going to kind of fly through a couple of these slides, and they'll be available, and you can certainly contact me if you want to talk more. But Thrive was built with using the interpersonal theory of suicide as a backbone. I wanted to include mechanisms of suicide prevention that were known to mitigate or reduce suicide risk. So looking at things like reducing, burdensomeness, increasing belongingness, decreasing a sense of hopelessness, and also kind of rethinking how we can develop a life with these things in it. That was part of the core theoretical model that we've been using to say, how do we start pulling these things into the very first care engagement moment to where they can make a difference, and of course, both suicidal desire and suicide deaths. Next slide. So I'm going to talk a little bit about Thrive-C and its components just to give people an introduction, and then I'm going to whiz through the kind of preliminary data that we have so far, because it's certainly a work in progress. But Thrive-C, or Thrive for Crisis, it has a couple of components. The first one is what we call a restorative suicide-specific alliance. The very first part of this brief 1-hour intervention is really focused on developing a safe place for disclosure. Because people come into these settings, as you all well know, being so concerned. People at higher risk for a suicide attempt, or who are seriously planning a suicide attempt, they often have very many concerns about what will happen to me if I disclose. And they might say something like, I was traumatized by my last hospitalization. I don't think I want to go back to a higher level of care. And some people have really positive experiences. They're there and connecting with us because other higher levels of care have been helpful to them in the past. So the idea here is that we teach our providers to say the first 5 minutes of this intervention have to be different. You have to show up in the room in a way that creates an experience for someone that's genuine, creates a safe space, and puts them at ease to say, we want to understand all of who you are. And we want to lead with our values here about how we want to share with you in the next hour, and listen and learn from you, and also think together about your life, with you being in the driver's seat of your life. So the first 5 minutes are really important in Thrive, and we use some very specific and unique techniques to create a restorative alliance, because as you all know, in crisis settings, we don't have a lot of time. We might have that one sit down, and we really have to make it impactful and meaningful and genuine every time, and tailored to the person and their multicultural identities. The second part, so once we create that safe space and really collaborate with the person, we kind of say, here's who I am, here's my values, including my Thrive values that I'm bringing to the table. And I want to understand who you are. What do you need from me for this to be a safe space to really talk about suicide in a way that you can put all of your thoughts and feelings into words? This is a collaboration, not a prescription, to really create what that needs to be for each unique person every time. The second thing we do is we really listen to the suicide crisis narrative. We ask people, tell me the story of how you came to a place in your life that you were thinking about suicide. I want to understand. And understanding the crisis narrative is a pretty ubiquitous, and if there's one ubiquitous, perhaps, intervention that cuts across most suicide-specific interventions that work, this may be it, which probably warrants more research. But it's really important, as scholars and practice partners have talked about for a long time, to share about the crisis narrative and to let the person be in the driver's seat about that. We also do an autobiographical life narrative to help put this narrative in context. We want to say this story about suicide is really important. It's what brought you in, but it's also not all of who you are. And so we use some techniques, including appropriate for CSU settings and sometimes inpatient settings, stones and flowers adapted from NET. To be able to put the story in context. And we have very specific trauma-informed strategies for helping people tell their life story to understand this in context. We focus on meaning making of the story, including those thoughts around how do we either get your life back or help you develop a new life that you can live, and then talk about, the meaning. We create a meaningful living plan. So what's unique about Thrive, because there's certain common elements with other therapeutic and other interventions, but it is very brief. It's appropriate for both suicidal ideation and attempt survivors. We do use some unique approaches in terms of interpersonal process psychotherapy and narrative and trauma-informed approaches directly in the intervention. And perhaps most uniquely, we're focusing on recovery from this first encounter. Whereas as I shared before, with many other trajectories, people believe that you can't recover until you've stayed safe first. And I think our sense that we wanted to say, could we actually start both at the same time? So. Okay, so I'm going to fly through some of the preliminary data on this. If you'll kind of advance several of the slides, and I'll tell you where to stop. Okay, so I'll pause here. So just to kind of give a brief preview, if you'll go one back, please. We recently published a paper on some of the preliminary results of this brief intervention. Intervention development is a big process. So we looked at the feasibility, acceptability, and social validity. In research, we tend to look at, do people like it? Does it work in the setting? And then we do additional research to say, does it actually work in terms of creating different outcomes, for example, compared to care as usual? So we're in the very early stages of this, and feel free to read the paper. You can look at the slides, but we did have very strong results on the feasibility, acceptability, and social validity of this intervention in a crisis stabilization center. And we're really excited by that, and certainly warrants additional research, which is in progress at this time. Okay, and then if you'll advance a couple of additional slides. Here's some quotes. If you go back one, and we did find that 94% of our individuals were able to engage. We have some markers to assess for recovery readiness, because there is some research suggesting that people who aren't ready to really focus on recovery may have an adverse response to it in some cases if they get overinflation of hope. So we're really excited to see that, Thrive is both a safe intervention, but also 94% of our guests demonstrated readiness to work on recovery, and they also really liked it. Some of my favorite quotes are like, past experiences in therapy have never made me feel this happy, or the difference is that I let my story counsel both of us. Or my favorite quote is, I think I would go to therapy if it were more like this. So we do think we're giving people a different experience, and we're currently doing additional research. Just to give people a preview, and then I'll stop in terms of where we're going next. As I mentioned, I currently have a multiple PI grant from NIMH with Dr. Tony Pisani, and we've worked with Connections and also now with Mental Health Cooperative to study a group, a Thrive, Belonging, and Giving group, to kind of put many of these concepts into a group environment and to start to look at that. And also to have a peer-led crisis follow-up program to where people are followed up for 4 weeks on the phone to help them make the care transition. We've learned so much from our peers, and including their unique role. And we're really excited as the data keeps coming in to be sharing that in community with you all. So thank you.
Dr. Lockman, thank you so much. This was really interesting. And just some great comments in the chat. Shauna Murphy, for example, notes, this isn't just treatment, it's owning your story, embracing your journey, and reclaiming your voice. So really powerful. Let's go to the roundtable. Oh, what? Wait, there's one more part. Post-presentation poll. We haven't done one of these for a long time, if ever. I really love this. So let's ask all of you, what part of Thrive C sticks with you? What resonated most with you about learning about this? Building a quick, authentic connection, telling their story in their own words, creating a meaningful living plan, feeling seen beyond their symptoms. So many I'm still processing. So go ahead and take a moment. And let's see. Yeah. So it resonated with people across many of the dimensions. So, and it looks like feeling seen beyond their symptoms got the most. Wow. And people are still processing it. It is, I love those quotes. It was really beautiful. It just seems like a really authentic connection. And that connection and feeling heard and understood is just core to care feeling like care. All right. Thank you. Let's go to the next piece in the roundtable. We have Bree Banks, who is a United Survivor board member and clinical assistant professor with Tulane University, as well as Adam Graham, who is a clinical and crisis consultant for TBD Solutions. So let's go to Bree Banks first. Bree, what is your response and what do you think?
Absolutely. Well, first, thank y'all for allowing me the space to be here and to share again some of my thoughts about Thrive and some of my background and context in working with Jennifer. So she and I have worked together for at least 100 years, started at Centerstone's Research Institute, then morphed into a lot of different stuff. I was able to work with her in the Thrive Lab for a while before coming to Tulane University in their Department of Public Health. And again, I've worked with Jennifer in a lot of different ways and training staff and working in Thrive and learning about Thrive and doing some research in Thrive. And there are two core things that I think really jump out to me about the uniqueness and the most kind of promising aspects of Thrive and the landscape of suicide prevention as we see it today. So, like I said, I currently teach in a school of public health at Tulane University here in New Orleans. Speaking of, I do live in New Orleans, and there's a mosquito flying around my face. If you've been here, if you know, you know. So I'm not losing my mind, so just bear with me if you see me batting stuff around. But one of the things that we in public health talk about quite a bit are called social determinants of health. And just a quick summary of what those are for those of us that may not be familiar. So when we experience different health outcomes, diabetes, asthma, heart disease, et cetera, for a long time, we traditionally looked at those things as either just diseases that happen within individuals biologically. However, what research has shown us, especially over the past 20 or so years in these kind of things, is that there are these kind of social and structural factors that impact the manifestation of disease and health outcomes. Things like economic status, financial security, education, experience of stigma and discrimination. And these things show up and essentially make health outcomes different based on our experience of those things. And in Thrive, what I see happening is it really bridges these kind of upstream elements of social determinants of health with downstream clinical interventions. And it does that in a way, specifically in two core ways that I see, one of which Jennifer had to skip over, so I'll mention it briefly. But one is in the Meaningful Living Plan. There's that mosquito. One is in the Meaningful Living Plan, and we had to zip through that slide. But in the Meaningful Living Plan, one of the things we do is we take patients through, again, it's a Meaningful Living Plan. We talk about safety, but the first thing that we do in the Meaningful Living Plan is help folks identify what their core life needs are. So not just how am I not going to die, if I'm going to try to live, how am I going to do that? And what are these kind of core domains in my life that I need, needs that I need to have met? And those include, again, financial stability, housing, spiritual connection, transportation. These are social determinants of health. And I've never seen in suicide prevention, I've never seen those things incorporated so intentionally and explicitly. And again, these things do impact outcomes. And there's been research kind of spattered around suicide prevention for the past 10, 15 years around these factors, but it's really starting to increase. There was a brilliant meta-analysis on this that came out earlier this year. But we do see that social determinants of health impact suicide outcomes. And in addition to that, what Thrive does, because again, we're incorporating peers, so we're promoting accessibility to care that way. And again, through these social determinants of health, we're creating space for folks to tell us and help us understand what their barriers to care are, what their barriers to engagement are. Instead of using those potentially as exclusion criteria or as indicators that they may not be ready for treatment, we're building those into the intervention directly as clinical mechanisms and as targets for treatment itself. Secondly, and again, I'll keep these as brief as I can for the sake of time, really, as was noted in the poll, is the humanism of Thrive. And I share this both from my own lived experience as a suicide survivor and a loss survivor, and from my role on as a board member on United Suicide Survivors International, led by Sally Spencer Thomas. And in that work, and as a clinician supervisor, a lot of different kind of intersections there. But in that work, I see so often that suicidal folks want a place to be able to come and share that they're suicidal, to be able to say, I want to die and I don't know if I'm ready to live or not. I don't know if I can. Again, without immediately being moved into assessment mode or risk mitigation mode. We need a place where we can be transparently who we are. We need it, we want it. And the research tells us that when we have spaces to be able to do that, we're more likely to come back to treatment. We're more likely to get better. And again, it's a way to create space for folks to show up as who they are, where they are, no matter how ready they may be to commit to life, or if they're not ready at all to commit to living or to be able to hope. But we don't ask people to suffer needlessly and Thrive. We don't ask folks to just stay safe, to do all of this really, really hard work to just stay safe without, again, at least the potential for hope. We help folks understand how and why we want to die, how and why we may want to live, and we can hold space for both. We can hold that ambivalence there, and again, not require folks be completely ready to live on day one. Because if they were completely ready to live on day one, they may not be here in the first place. And again, so it's a way to, I think it creates a space for many folks who are suicidal that may not seek care, or if they have tried to seek care, may not even be eligible for some of the most evidence-based treatments that we know that exist. And so I think Thrive steps in several different ways to fill a very unique gap in suicide prevention treatment, in a way that I've never seen as a researcher, clinician, or as a patient who has sought suicide care myself.
Bree, thank you so much, and thank you for sharing your personal experience as a suicide survivor as well. Really honor you. And it's so important. It seems to be able to really talk about this intervention from the inside. And so especially appreciate your perspective. Thank you.
Absolutely. Absolutely. And I will just one last thing, just again, share out of my experience. I use the Meaningful Living Plan. I use it. I have recurrent suicidal ideation. I use it every month. Every month, whenever my suicide ideation spikes, I use it. And not only does it help keep me alive, but it helps keep me living in the best ways that I possibly can. So really good job, Jennifer.
No, thank you. Thank you so
Absolutely.
much. And let's go to Adam Graham. Adam, what are your thoughts and your perspective?
Yeah, absolutely. And Bree, so well said. And thank you for sharing those thoughts. When people ask me what I'm most excited about in crisis services going forward, without hesitation, like it's Thrive. You have to learn about this. I'm so excited that Jennifer got to give a glimpse of this. And there's really two dynamics about Thrive that really resonate with me. And to back up a little bit, I've had the great privilege of engaging with Thrive on three levels. One, I'm trained as a Thrive practitioner. I've been able to give Thrive to a lot of folks. Was also a crisis director at the site early on, so I got to see it from an administrative level, how this might fit in. And now as a consultant, I get to work with crisis centers across the country to see how this might fit in a variety of contexts. So from those angles, there's two things that really resonate with me about Thrive. The first is how honoring it is of folks because of how engaging it is. There's always this tension, right, of how much do we encourage and corral folks to go through our system, to go through our process. Like we have processes for a reason, allows us to serve a lot of folks, but how much do we say, all right, you got to do this, this, and this. This is how you move through the crisis continuum. And how much do we go to folks and say, hey, I hear you. You don't want to get out of bed. You don't want to talk to anybody. You don't want to do anything. I've done Thrive sessions with guys who didn't want to get out of bed, like rolled over. It's like, hey, can I talk to you about your story here? Like, yeah. And by the way that it's approached, by the radical honesty and autonomy that frames Thrive, we were really quickly be able to start a conversation that really meant something, and had some really great successes with that. And so I love that folks don't have to do a lot. We can come to them and say, no matter what your experience has been, no matter where you are today, we care about you. We want to know about you. And we think we have some tools that can fit where you are to help you move towards a life worth living. So I love that, the engaging part of it. And the second part that really is the part that gets me excited the most is that when I have the great privilege of working with a crisis center, pretty quickly you can tell what's at the center of the service. What does it center around? Like, what's the most important thing that happens here? There's a lot of things that can take our focus. Like, it's really important to have safe and efficient admission criteria and procedures. It's really important to keep people medically safe on a unit and to make sure that we do the things that we're supposed to do to fidelity. And it's important to have good follow-up plans, all these things. What I love that Thrive does is it offers, in the midst of that really important context, and says the most important thing is not just about trying to make something bad not happen, but how do we grow something really good? Like, why in the world would you want to go through all this stuff in the first place? Why would you want to do the hard work of recovery if there's not a reason to? We want to talk to you about what it is that makes life so painful that the death is on the table for you. And then what is it that can make life worth living? And Thrive uses really smart mechanisms to activate a way of thinking around that and to go through it with someone who cares. So just from the one-to-one level, the systemic level, or the agency level, and now seeing on the systems level, seeing a crisis service that's oriented around what is it that makes life worth living. It's been so refreshing to see, and really excited to see where Thrive goes from here.
Wow, Adam, that is amazing. I love what Bree said in the comment there. Just not dead isn't good enough. Thrive lives this message. I absolutely, that's incredible. And I think that's what people are looking for, when they're calling 988 or they're going through mobile crisis or going to a crisis stabilization unit. It's not just about only being safe, it's about why. And that engagement. And just the way you both come across, all of you come across, is just that caring connection. How important that space is to really care and engage. So thank you so much for being on. And I would love to hear more. There are some that want to hear more about what a meaningful living plan is. So very cool. Okay, thank you so much. Let's shift to Dr. Richard McKeon from SAMHSA to provide a SAMHSA update. Are you on, Dr. McKeon? Wonderful.
I am on. Thank you so much. And that was a wonderful presentation. I'm reminded very much of Marsha Linehan's dictum that the best suicide prevention is a life worth living. So it was great to hear about that work. I'm sitting here with Brian Sims at the Rural Certified Community Behavioral Clinic Crisis Mapping Academy that is being put on by the Center for Mental Health Services at SAMHSA. So it's a wonderful opportunity to talk about crisis systems issues in rural communities and the roles of the CCBHCs. And next week, Bethany Myers has been doing a great job of overseeing this. We'll do a full report out for SAMHSA as part of the crisis jam, more than I'm able to do today. We're midway through this wonderful policy academy. Just another couple of quick things. Earlier in the crisis jam today, you saw the information about 2 upcoming webinars to assist you in preparing for 988 Day on 9/8. And so that an important opportunity to continuing to promote awareness of 988. And of course, 988 Day takes place in September, 2 days before World Suicide Prevention Day and during Suicide Prevention Month. So I also want to mention that earlier today, the Suicide Prevention Resource Center released a 2-page resource for anyone who wants to get involved in Suicide Prevention Month. And you can also access that through www.sprc.org. So thank you very much. That's all from me.
Great. Thank you so much, Dr. McKeon. And let's go to Louise Johnson from NASHBID, who is a senior advisor on child issues. Louise, please go ahead. Great to have you on.
Well, thank you. And everything before me really leads right into what I'm going to talk about. It really is an example of a crisis center that was started in my home state that I worked on. And it's really exciting. It's called, we call it FOCUS. Stands for Family Options in Cherokee Union in Spartanburg County. And why that area? Because it was the fastest growing Hispanic population. We found that most of the kids that were being hospitalized in acute care hospitals came from the area. And so that was, that was really what was behind it. And it was a SAMHSA grant that really helped us kick it off, a system of care grant initiative that really helped us to get this moving. But I'm always saying that how important it is that, as far as when we talk about where are the solutions, when we talk about these kids with complex needs, and the solutions always lies in the communities. And so there was a behavioral health coalition that was already trying to address some of the issues. Parents were complaining because a kid could be upset in school and say, I want to kill myself, and they have to follow protocol and send the child to the emergency room. We found that the emergency room was not child friendly, not family friendly. So we worked in partnership with the local hospital that was really being overrun by children being sent there. Mainly, a lot of the referrals came from schools across the 7 school districts. And partnership, and the school district, the hospital really supplied us our crisis center. And that started out as far as the backbone of what we would do in the area. It's called the CAFE, Child and Adolescent Family Engagement Center. And what I like about it is it is youth and family driven. The first experience is by family members that have had youth with various experiences and have had our lead parent support specialist. He was one at first that really hated the mental health system because he adopted 2 kids that were schizophrenic, and he really struggled in trying to get the care that they needed. And so what we found that is so important, especially in poor rural communities, that relationship is critical. And so why the family and the youth leading the way as far as in meeting with them first and engaging them, telling them a little of their story, that we found that we have more repetition as far as people coming back. Being able to follow up and care, they really seem engaged, knowing that this is not some person that they feel intimidated by. And they also are very involved as far as in doing the follow-up care. And so that's been those are key parts of the success that we've experienced. We really were trying to bridge the gap between, and really change the trajectory from kids having to go straight to the emergency room. And, we had to do some policy changes, because once the school calls and the child is placed in an ambulance, and that's a huge cost to families that are really struggling. We found that once that happens, once they call the ambulance, they had to take them to the emergency room. But the beauty of partnering with the hospital, and they provided us, like I said, the building is really in close vicinity to the hospital. And so we were able to redirect Oftentimes, we're able to keep families from having to pay that huge cost. The emergency, if they come to us first, if we need to go take them to the emergency, we will have someone really carry them to the emergency room. And we've even offered through our vehicle, instead of schools putting them in an ambulance, we will also transport to our, to see what's going on and see whether even an emergency room is necessary. And the hospital has really loved this initiative. They have reduced, as far as young people coming, by 60% to date, using the emergency room. And they often refer and say, well, you can go what we call to the cafe. And like I said, and we really do a thorough assessment. We have a number of different options for family members. And when they come to us, and if we find that something may happen, if we send them home to the community or back into the community right away, we have short-term respite. One of our partners ran a group home. And what I love about that is that care coordination, as well as our family peer support, they go visit them at this group home setting. And the group home setting is so wonderful because they get to know the family, they get to know the kid, what the kid likes to eat, rather than see with the lights on. And so they go the extra yard to make sure that they are comfortable. And so, but if we feel like we have to do that, so in partnership with child welfare, families will have to agree to brief strategic family therapy. And so where we work with families closely in the home, and the whole goal is to keep that family intact, to keep that. And also part of the initiative is foster families. We found that a lot of disruptions have been happening with adoptive families. And so, and foster families. So we work with those families as well if they're in crisis to come to utilize the cafe. So it's been a very, I feel like I'm rushing because I know that we have limited time. But anyway, it feels like it's been a very helpful situation. I want to quickly read one story of a success story, a cafe student. She was new to the district. Her name was Ariella. She was referred to the school by the school due to her aggressive and self-harm behavior. By the end of the first week, she had become disengaged and was lashing out at teachers and other staff. She started refusing to go to school, and her family did not want to damage the relationship with their daughter or the school district for that means. She also experiences some vision and hearing difficulties, and this is part of what some people call as far as complex. And her family is also very mobile. They had moved five times in the last 5 years, with the first move being from Puerto Rico to the mainland in the United States. So the cafe, we completed an assessment, suggested school-based counseling. We worked very closely because that was part of our system, placing clinicians in the schools, and as well as having the family involved with brief strategic family therapy. So the family peer support specialist met with the family twice a week to prepare for the transfer and working with them around the IEPs that's done in schools. A detailed crisis plan was completed. And she first met with the school-based counselor virtually and then began attending half days and was finally introduced to full days back into the school. And the last thing that we heard that Ariella led the entire school in the Pledge of Allegiance and is really successful in being re-engaged and being able to make it in that school setting. So that's just an example. I'm a big proponent of a place to go. And I'm really concerned about what's going to happen to some of the poor in the poor rural communities with limited access. Some of our families are 45 miles away from the closest ER anyway. So so these options, I think, will be absolutely necessary and critical, that we have more options for families. And families, when they're in crisis, they want to take them somewhere. They don't, and they're used to being able to to take them or send them somewhere in order to initially address the crisis. But like I said, the biggest success is the engagement.
Louise, thank you so very much. What an incredible experience. And we know your leadership was absolutely key in implementing that. And we are so happy you're at NASHBID to share your insights nationally. So thank you so much.
Thank you, Megan. Thank you for having me here.
Absolutely. And so just coming next week, episode 228 is a fireside chat, preparing for a career in crisis care. And Dr. Jonathan Singer will be part of that fireside chat. And the week after, in 2 weeks, episode 229, live and on location follow-up. It's funding the SLC Crisis Center. And Representative Steve Eliasson, as well as Kevin Curtis, will be part of that. And the neat thing is, it's really following up on a lot of questions, funding-wise, that people had when talking about the previous live and on location center there. So thank you for watching. Everybody have a great rest of your week. Thank you so much. Take care.